So sorry for the delay, everyone. Thank you for your patience. So I'm Dr. Hanna. I'm a psychiatrist with Northwell, Central Health Hospital Northwell in Long Island, and I'm here to present information on the partnership between the Republic of Guyana, GPHC, and Northwell Center for Global Health, as well as the Department of Psychiatry. So the goals of this partnership are really to support Guyana in expanding psychiatric services nationally and regionally. So just some orientation. So this is where I live now in the U.S. And then we're all the way up there in New York, Northwell. And so this is the physical location of the central region of our health system. It's the largest employer in the Northeast, and this is Long Island, which is composed of Queens from the west, and east is also called Long Island. And we're our main psychiatric hospital. We have several, but the main one is Central Health Hospital right there. Right, so that's kind of this context, and will be important to for later on when we're talking about like people coming into new relations with us. Right. So I want to just show you, this is Dr. Eric Troy Pena, who's Northwell's Director for Global Health, CGH, and he is going to be talking a little bit about just the mission for CGH in Guyana, like how we really want to help support.
Global Health interview, take one. So we went to Guyana, Georgetown, Guyana. Was the Center for Global Health, and approximately 6 departments and service lines represented by 16 health professionals to meet with Georgetown Public Hospital Corporation and the Ministry of Health and the University of Guyana to set up a 5-year agreement based on their need and our ability. You know, global is local and local is global, and if anything the last year and a half has taught us is that we're all connected. And so what happens in Guyana doesn't actually stay in Guyana. There's actually a connection. We have the largest diaspora of Guyanese Americans in the United States, right here in Queens. We take care of an enormous number of those people as patients in our health system. We have an enormous number of those people working for us in our health system. And so it's just important to really speak to, if you're going to do global health, we should do it in countries that we have a cultural context to understand and that will help improve our cultural context back in the States.
We are looking for opportunities where we can send our doctors to upgrade their skills, to be able to see how things might be done differently in a more developed country. And at the same time, I think we can offer to Northwell and to your residents an opportunity of coming to Guyana and practicing tropical medicine.
It's that interplay. It's somebody who's from the Guyana diaspora, who's now a senior executive at Northwell, coming in and saying, I want to give back to where my parents grew up. I want to give back to where I have an uncle that still lives in the country. I want to see the health and well-being of my countrymen elevated.
So my family's from Guyana. I spent a lot of my time here over the course of my life. So I have a vested interest in the welfare of Guyanese citizens. This is a beautiful opportunity for me to contribute back to my own culture and country, and so it's a win-win.
On the other hand, with Guy, it's about, I take care of these patients every single day, and I have very limited understanding of what their understanding of healthcare is.
Haven't had years of experience interacting with Guyanese patients. I know how they're like, but it gives me a different look on how they are, where they come from, how they lived prior to them immigrating to New York. So it gives me a different perspective as a clinician. This is where they were born. Now they're in New York, they're New Yorkers, but in their heart, they're still Guyanese.
We get these, articles that get pushed out, 4 hours after we sign an agreement with the Minister of Health and and GPHC, and immediately following that, he's got people who are in the Guyana diaspora texting him from Queens, being like, "You're on television."
No, we gotta speak 100% candid. Because it's our people. We have to.
It's already out in the Guyanese community.
When it wasn't New York that was covering it yet, it was Guyana, and it's because you've got a Guyanese American population that's so clued in, and it matters so much to them what happens in their home country.
There's a saying that it's a spirit-taking world, and we could feel that vibes from both sides. Northwell, many of the hospitals that they are servicing in the U.S. is where we have a large Guyanese population. And we are happy that we can build this relationship. So, and we can feel safe that our family in the US can say Northwell is having a collaboration with a Georgetown hospital. Northwell is good. By extension, they can feel that the service for their family can improve and they can have some sense of satisfaction.
So Secretary Planner for CGH, I just want to introduce you a little bit to the psychiatry at Northwell leadership team. So Dr. John Q. Young is the recently promoted to chair of Zucker Hillside Hospital, senior vice president for behavioral health service line, and also for medical education for Northwell. So he's the head of this project, and I'm kind of the lead in terms of on the ground, running the psychiatry portion of the mission plan. My name is Hanna, and I am director of anti-racism and social justice for the residency program. Also assisting mainly with parts of the plan that are related to education, expanding the guidance residency program, and related to coordinating Guyanese residents coming over to train in Northwell, and then vice versa. We have Dr. Timothy Cryer, who is director of the advanced clinical experiences for Northwell medical students. This is our kind of small leadership. Okay, so going to be reviewing seven goals that we're having to really try to support. Our role is to really kind of hear what our guidance partners need, and in any way we can use this. Guidance really leading, and we're here to just support. But first goal is to standardize, coordinate, and augment access to the quality of mental health care, with an emphasis on suicide prevention. Second is to do the same, standardize, coordinate, and augment the quality of substance treatment services nationally and regionally. To enhance clinical services at the Georgetown Public Hospital Corporation Department of Psychiatry, and also at New Amsterdam Psychiatric Hospital. To help create a forensic hospital within the prison system. Enhance the Masters of Med in Psychiatry, the guidance residency training program, and also to offer away electives, training abroad. So to invite Guyanese psychiatry residents to come and train at Northwell, and at the same time also have our residents come over here and do psychiatry rotations at GPH. So this is a slide from a Northwell medical student, a Guyanese American medical student at Northwell, Alex Martin, presented this in his presentation earlier this morning, just showing the one of the main needs. The suicide rates in Guyana are quite high, second globally, and so we have this in back of mind as we're thinking about ways to really support the expansion of the mental health services nationally to try to make this better. So I just want to emphasize we've had at least three. There might have been a fourth trip back and forth, and we have really from Northwest only experienced very welcoming and accommodation. We really want to thank you and your countrymen for being so kind and welcoming to us, and it's been at every level, right? We really have been welcomed all the way from the top at every level from the Ministry of Health, from GPHC New Amsterdam, from the different departments. Everyone has been very accommodating and supportive of the plan. So much thanks. This is our ECT team. So Dr. Sangani on the left and Dr. George Petrides, they are co-directors of the ECT services at Zucker Hillside Hospital. Now, our ECT service is the second largest in the US. They treat about 30 patients every day. And then if we're gonna go all the way to the right and come over, then there's Lizelle Mangabut, who is the nursing manager for the ECT service. The three of them are here in the country. They're currently over at New Amsterdam Psychiatric Hospital, with Dr. Raj Kumar, just taking a look at the hospital and trying to see kind of how really game planning how we can bring ECT to help with the suicide challenges in the Guyana. There's me on the tall one, and it's Dalia right next to me is a coordinator at GPHC. So they're all over at NPH at the moment. And this is just from the party last night. Okay, so for the first goal, standardize and enhancing guidance mental health services. So some of the things that we have been working on and also plan to continue working on: mental health legislation, mental health screening tool for primary care, standardized interventions to complement the MH gap, which is like a 9 or 10 point primary care algorithm for different aspects of mental health that's used globally. The standardized interventions would be assisting with developing treatment guidelines, using guidelines for evidence-based pharmacotherapy, a measurement-based care strategy. This is something that we've really expanded a lot in the 10 years I've been at Northwell. Like, how do we know patients are getting better psychiatrically when there's no real biomarkers to kind of like track with standardized measurements to see how well people are doing. Trying to improve suicide risk, violence management within inpatient settings at GPHC and NPH, and assisting with staff training for all of the above. So I've highlighted a couple of things. Just there's a couple of things that I just throughout the presentation will be highlighted, so I want to expand a little bit on in terms of the mental health legislation. So the current updated legislation just updated recently this year from the last version to 1930s. So we were very happy to assist in like reviewing and editing and adding comments to really try to model based on some of the policies and procedures that we have in the US and New York in terms of the legal practices. So I'm going to highlight a couple of things. I'm going to highlight some ECT stuff, but also just overall recovery orientation. Recovery model, as we were reading through, was the real model we wanted to include in the legislation. So if we look at traditional or like medicine model-based definitions of recovery, what does that mean? If you look in kind of articles or literature, recovery might be meaning returning to normal, full symptom remission, getting back full or part-time to work or education, independent living without supervision, having friends to engage in activities with, and usually the definitions of this in literature is like sustained. So these sustained practices for a period of 2 years, right? So this is all good. This is all good, but we don't really. One of the I guess challenges we've had in the US that we've really tried to learn from historically is like not limiting the definition of recovery to these things, which are excellent things, but we really want to have the recovery focused and centered on the people who are most involved, right? So recovery also means a deeply personal, unique process of changing one's attitudes, values, and feelings, goals, and skills, and or roles from pre to post diagnosis. It's a way of living in which the person feels like satisfied and hopeful and is living a contributing life, even though there may still be limitations caused by mental illness. In a way of, it's also the development of new meaning and purpose in one's life as one grows beyond having first a mental illness. So it's like, you don't necessarily have to go revert back to how things were before. Oftentimes you can, but when you can't, it's just kind of like finding joy and meaning in your life, even though things are changed a little bit, right? So these are also recovery. So philosophy for recovery model is using shared decision-making and supported decision-making. Shared decision-making is usually a model we use in terms of like the patient-doctor relationship or the patient-mental health provider relationship to try to really have the patient be the driver of decision-making. It's based on a philosophy that optimal decision-making occurs when decision is informed by the most relevant evidence. That's the mental health provider's role to bring the evidence. But then the other piece is that the person who is taking part in mental health services, their preferences and values, they're the ones who are the real experts in that. So both have to be considered in shared decision making in terms of treatment. Now, support decision making, this is more like thinking about structures and legal, as opposed to like the dyadic experience of the patient and doctor decisions for treatment. Supported decision making, the goal is meant to replace paternalism in mental health. Substitute decision making. Oh, the person, they can't decide for themselves. They have to have the court or family or parent or someone else decide if they're mentally ill. Like, not the best thing. Best interest decision making. Oh, well, the person really wants this for the life, but that's not in their best interest. We should do this instead. You know. And instead it's meant to promote the rights, will, and preferences of the individual. And the assumptions in the support decision-making philosophy are that all people make decisions with the support of others, right? Every decision comes with risk, right? So example, I'll give a small example, right? So oftentimes I work in first episode psychosis, an outpatient clinic in New York. Oftentimes you might have a person who says, I really want to live independently. And then based on, this is actually usually quite possible, but I just want to caveat that's usually quite possible. But there are some cases when, it's more challenging. So say a person who maybe based on symptoms, it's not really, like as a doctor, I'm thinking, okay, this might not really be so successful. A support decision-making mindset would be, okay, well, this is the person's real goal, let's work for it. And even if it cannot be sustained, oftentimes the ability to make the choice try is valuable for the person, right? And that we're talking about people with mental illness, but people with mental illness are the same as people who haven't had struggles with mental illness. We're all the same. This is the equivalent of, oh, maybe I might not be personally diagnosed with schizophrenia, but I've taken risks in my life and depended on people to help me make decisions was my decision, right? I took a risk to take out a bunch of hundreds of thousands of dollars of loans to go to medical school when I was a teenager, right? That's a big risk. I did it. People helped me make the decision. I'm no different from my patient who might have schizophrenia, making similar risks for their lives. It's like the dignity of risk. People have a right to make risky decisions for their values and preferences, right? Respecting the dignity of risk. So these philosophies share decision making and treatment and supported decision making within the structure of mental legislation were really the guiding philosophies that we used when we were trying to add our comments and edits to the Guyana legislation. So I want to also highlight a couple of things. This is just a screenshot of some of the comments on the legislation. And this is just a comment on ECT since we have ECT in here. It's effective treatment for treating refractory depression, also for psychosis, also for mania, also for catatonia. And it's very common in geriatric psychiatry conditions. I think this was us trying to advocate for not making prohibitive restrictions in the law against some of these treatments that are super effective, super safe, but just super stigmatized everywhere, right? So to not make it illegal in the Guyanese context, so they can help so many people with suicide and other things. So this is just us really advocating to make it easier for people who choose, not mandate who choose some of these treatments to be able to access them through Guyanese law. Okay, so addiction services is the second goal. So develop public sector options for treatment. So right now it's only Phoenix House and Salvation Army to develop public sector government options as well, and also decentralized care. So addiction treatment only being long-term and residential is not. It's one option, but we want more and more options. We have options for people to be able to be living at home and working and also having outpatient addiction services. This is one of the things we want to help support. We want to help support developing a substance abuse screening tool for primary care. We use the DAX and the audit at our hospital, but SBIRT is another common one. So we're just trying to figure out what's the best option for the Guyanese context. Standardized treatment guidelines for substance use, policies, features, and protocols in inpatient settings, and also this is huge vocational and rehabilitation services. Oftentimes for treating substance abuse, like for many people, substances are used to self-medicate, mental health problems, and you have to really replace it with something else. So it's like you're not getting rid of the substance, yes, but you're trying to help people build a life worth living so that they're not having to rely on substances to deal with the challenges of life. It's very difficult for all of us. And training for all of you. Enhanced services at GPHC and New Amsterdam psychiatric hospitals. So infrastructure considerations. So some of the ECT team going, the past visits we've had, the ECT team visiting GPHC and now New Amsterdam are part of this kind of advising on space, facilities, and staffing. Establishing ECT services, safety, patient safety and staff safety policies, procedures, and protocols we can help with. In particular, things like restraints, seclusions, and how to and also kind of de-escalation strategies, how to when we have to do it for the benefit of the individual, do it in a safe and humane manner for the individual and also safe for staff. I'd like to help with those, to help expand the psychopharmacology formulary, enhance clozapine use, introduce inpatient, outpatient, especially inpatient brief psychotherapy strategies. When people are inpatient anywhere, just having them just be there and taking meds is oftentimes will not help their mental health. The longer, there's data that we have that the longer someone is in the hospital past a certain point, their mental health actually declines. So when you're there, you want them to be safe, getting appropriate medications, but not just hanging around, not doing anything all day. You want to having like an environment that is conducive to healing. And adding some of these psychotherapies in the training of nurses and residents can really be helpful. Point of care lithium level testing. Oftentimes, to manage certain medications safely, lithium as one of them, you have to be checking levels to make sure the level is not toxic in the blood. However, if it's difficult to get the lab to send the levels back in real time, it makes it really challenging to use certain medications, and staff training for all of the above. So some of the things I've highlighted, right? ECT, lithium, clozapine, and especially DBT skills. These are all things that have evidence in really helping with suicidality. And so these are some of the targeted interventions we're hoping to assist with. This is just some pictures of some of our meetings while we're here. This is the ECT team meeting with the GPHC faculty while they were here, and Dr. Lopez from the residency. Also, there's Dr. Morgan up there with Ministry of Health. Here, this is part of the infrastructure advising. This is kind of looking at the temporary inpatient unit GPHC in the infectious disease area and the kind of the build out below. Here's the CT meeting with Dr. Ramirez and his team from anesthesiology. Dr. Ramirez is in town. He actually just got back from New York, but before we left, we invited him. He observed an ECT procedure at Northwell. And this is us here at GPHC meeting with the rest of his team there, just because ECT is a treatment that involves psychiatry, anesthesiology, and recovery nursing for it to be enacted. And this is here us in the build out for the psychiatry department at GPHC, just brainstorming about spacing for introducing ECT services for treatment rooms and for recovery units. Right. Now, no one here was in the 9 a.m. presentation, right? Okay, so I'll play this. This is repeat from 9 a.m. This is just a patient at Hillside talking about how ECT services have really helped her.
I learned about ECT because I had hit a point where I was at the end of my rope in terms of treatments. I started in February of 2015, and the reason I can remember the month and the year so well is that was the latest and last suicide attempt I had. The results have been literally life-changing. There were fewer ups and downs, and then when the ups and downs would hit, the ups weren't as high, the downs weren't as low. So it felt like my world started leveling out.
There are many patients that can benefit from ECT. Patients who basically have a mental illness that is not helped by medications or psychotherapy, and it's severe enough to disrupt their lives.
I come every 4 weeks, and it works wonderfully.
We induce a seizure by stimulating the brain with the electrical stimulus. It's like rebooting the computer. It's not going to change the capacity of the computer. It's not going to change the hardware, but it's going to, let's say, debug the software and let it work. the way it should.
The actual process and procedure is painless, is simple, is easy, and is not scary.
In many movies, it's portrayed as a form of punishment, which is far from the truth.
I'm in my sweatpants and comfortable shirt, and they run an IV, and the doctor gives you some medicine. I go to sleep.
The patient does not feel anything. The seizure lasts for maybe 30, 40, 60 seconds. The anesthesia by itself lasts for about 5 minutes, so making it one of the shortest procedures in medicine in general.
It's made a drastic change in terms of what I can do now, in that my relationships with my husband, with my parents, it was so hard for them to go through all of these things, standing there, and a lot of times feeling helpless. Now I can have so much more to my relationship with them because I can interact on a much more stable level, and I can interact with them on a much more even keel. I have so much more happiness in my life than before. Not only happy to be alive, I want to be alive, and I want to be happy.
So this is a clip from this morning. This is Dr. Sangani, who gave a much more extensive presentation with a lot, like some really moving before and after images of patients recovering as a result of ECT, which, those we can't show, we can't record, but I did want to play him explaining the procedure and him talking a little bit about safety, since this is one of the safest and most effective, but also most misunderstood and most stigmatized treatments in psychiatry. So he's going to talk about what treatment is, and then also about part of the reason why it is so unfairly maligned by the world.
Using electricity to stimulate the brain for a few seconds to treat different psychiatric conditions. And when we stimulate the brain, it produces a small controlled seizure. So the word E, letter E stands for electricity, C stands for convulsive, and T is therapy, so ECT, electroconvulsive therapy. It is done under anesthesia. It is a controlled seizure, usually stops within a minute, and it's a very safe treatment.
This is video I took on my phone from this morning here at this conference, so that's why the audio is a little bit wonky, but here's I'm talking about some of the safety issues.
To get sometimes spinal injuries or joint hyperextension and joint dislocation. To prevent that, they were administering succinylcholine, which is a muscle relaxant. Succinylcholine as a muscle relaxant cannot be administered when patient is awake, because it also paralyzes respiratory muscles and you cannot breathe on your own. So that's why it has to be administered under anesthesia. It's mainly that period of 4 seconds. The seizures itself are clonic in nature. So there's a contraction, relaxation. That does not produce any injury. Before anesthesia, when they had to do that, to prevent that tonic contraction, you would need to hold the patient so that they don't hyperextend themselves, they don't go all the way backwards, and they don't sustain injury. Now, when all your muscles are contracting together, if your respiratory muscles are also contracting at that time, the air can come out against a closed vocal cord or closed voice box. And at that time, it may come out with an ah kind of sound. So for a bystander, 4 people are holding the patient and there is a contraction happening and you are hearing this ah sound. Patient is not aware. You cannot be physiologically it's not possible that you can be aware when you are having a generalized tonic-clonic seizure. But for a bystander, that used to give a bad view, and it would look like barbaric, and that gave ECT a bad reputation around that time.
And that's historical ECT. As you saw in the first video, because of use of succinylcholine and brief anesthesia, like there's not even like all you see is this little foot. This is all you see, and honestly, to even see that, they have to have a blood pressure cuff around the leg to prevent the succinylcholine from getting to the leg. And they're just monitoring this little seizure to make sure they're actually having the seizures, since that's the treatment. This is the only movement for most of the procedure, which is 30 seconds. 30 seconds in duration. So plan for ECT services in Guyana. First is device acquisition. We're brainstorming on device acquisition. While we're doing that, we're working on standardizing treatment guidelines, protocols, policies, and procedures for kind of the operation of the service. And then once 1 and 2 are done, we're going to be working on training and technical assistance for the personnel in Guyana. This will involve inviting psychiatry faculty from GPHC and NPH, as well as nursing and anesthesiology, to come over and take our ECT training course, which is a week-long, can accommodate 3 psychiatrists and 2 additional persons, maybe 1 nursing and 1 anesthesiology per session. And they perform this course almost on a monthly basis for several years. I took this course in residency, and actually also Dr. Sangani. He and I were 1 year apart in residency. We both trained under Dr. Treatments. Also, this would involve inviting residents from the Masters of Medicine and Psychiatry program to come and do rotations in Northwell. But while they're here for like a month rotation, it could include half day a week or day per week, also rotating on ECT service to be more comfortable with the procedure. Okay, enhancing that program. So going on to 6 out of 7 for the plan. Guidelines and algorithms for evidence-based psychopharmacology, CBT and DBT skills training, direct observation and feedback, which is rare even in the US. Like our program has a direct observation and feedback program for residency, and using rating scales to track progress in terms of patients' outcomes. Routine medical condition management, quality, improvement of patient safety strategies, and continuing medical education and research resources. These are all some of the things that we're doing at Hillside that we're hoping to assist as appropriate and as based on the needs to the guidance residency program. So I highlighted continuing medical education. I just want to touch on this. So we have almost every week, every Wednesday, 11 a.m. Eastern Standard Time for most of the year, a Grand Rounds series of education in Northwell on Zoom. On Thursdays at 11, we have a child Grand Rounds. So this actually, Dr. Tang is on faculty here, a researcher at our hospital. She presented today at 11, and we have people coming and presenting every Wednesday. There's for people interested, there's a program for this year. There's the child Grand Rounds, and then they're recorded so people can access the recordings. Now we have collected names and email addresses of the psychiatry faculty here to add to the distribution list. So they're going to get the email to start getting emails to access all of these educational programming, and anyone who's here who contact me after the presentation, I can get your email to if you're like medical personnel guy, and I can add you to the distribution list for this. And this is just an example. This is like a short example. I had to scroll, but this is the beginning of like the some of the people who have come, and you can having the link and access the past educational materials. Okay, here's the Guyanese residency program. It's a 3-year program, Master of Psychiatry based on the CanMed method, and it has 4 clinical tracks, 4 tracks: clinical education, research, and leadership. And this is where we're going to help add whatever they would want for expertise we have. the last part of our strategy with Guyana is the mutual educational exchange program. Away rotations abroad both ways, right? So we would have Masters of Medicine and Psychiatry residents coming to Northwell for observerships and rotations, and Northwell residents going to GPHC. And we actually have identified the first Northwell resident, Artune Alexander Desir, who's hoping to come in February or April of 2023 for a month rotation. So also GPHC and NPH faculty, residents nursing and anesthesiology coming to Northwell for the ECT course, and GPHC faculty also coming for addiction training. So here, and just to get a sense of, for faculty residents who are coming over to train at our program, this is a little bit of like what our residents do in their 4 years. These are the experiences, the kind of like the options. So I think inpatient experience would be really, really good to see, but we want to really customize as more residents come from Guyana in terms of what their needs and interests are in terms of coming and see what's happening. And then I want to show you another brief video just to get a sense of like if a faculty member or a resident is coming to Northwell, like this is the program, this is some of the facilities.
I'm John Young. I'm the Vice Chair for Education and the Program Director in the Department of Psychiatry at the Zucker Hillside Hospital. At Zucker Hillside Hospital, we have a residency, it's a total of 52 trainees, 13 per class. We're looking for students who want to become outstanding clinicians, excited about clinical psychiatry. They want to learn how to bring healing and care to folks who are suffering with mental illness.
When I was looking for where to come for residency and where to apply to, I was looking for a place that had an independent campus that was focused fully on behavioral health. It doesn't hurt that Zucker happens to have really world-renowned researchers.
Our vision for Zucker Hillside Hospital has always been to be a really outstanding facility for clinical care, training, and cutting-edge research. And it's our belief that you have to be excellent in all three. We see a very diverse array of patients.
So Zucker Hillside Hospital is situated right on the border between Queens and Long Island. Zucker Hillside Hospital is an amazing freestanding psychiatric campus. It has over 240 inpatient beds, different types of subspecialty units ranging from affective disorders to first episode.
We have a geriatric unit, an adolescent unit, a women's unit, a college unit, and during your residency you have the opportunity to rotate through all of the different ones.
We're about helping trainees find where the passion of their heart meets the need in the world, and that's what we call calling. Northwell Health has a Center for Global Health. I'm really excited that psychiatry has created a global mental health initiative, and we are partnering with communities in South India, in Ecuador, and Guyana right now. And those experiences give us opportunities to provide care there and support, but also deepen our commitment and engagement with communities right here.
This program really challenges you to not just be a physician, but to find a place in this community, in this world, which is pretty awesome.
So some of the other hospitals, there are potential options based on kind of what we can arrange for transportation, or South Oaks and what's the other hospital? I forget. Oh, North Shore Community Hospital. That also have psychiatry programs, CL and some inpatient opportunities at South Oaks. So this is just like a orientation to our organization. There's Northwell Health, Long Island Jewish Medical Center, which is 3 hospitals next to each other. One of those 3 is Zucker Hillside Hospital, which is our freestanding psychiatric hospital, and our residency program falls within Zucker Hillside Hospital. And Northwell Health and Hofstra University have a partnership similar to how UG and GPHC have a partnership, and the School of Medicine is a I guess product of that partnership. Here are, since you saw the Zucker Hillside, these are just some pictures of the other couple of hospitals we can maybe arrange for people to come and do rotations when they come. This is North Shore Community Hospital in Manhasset, and they have a CL service that might be of interest to visiting residents from Guyana. and this is South Oaks Hospital, which is a little bit further out. Whether or not we can support people coming here depends on kind of some transportation challenges. It's a little bit further out, but it has some unique things like inpatient child units, a dual diagnosis addiction, and psychiatry inpatient. So here are some possibilities. We really want to customize the needs and requests of the guidance residents in the residence program, but a possibility for a way elective would be inpatient primary rotation at Second Health Site for a month, maybe a day or half day a week on our ACT service. Let me see, we have Thursday afternoons, we have didactics. And the primary logistical contact in country would be Hanna Marler, who's a project manager with CGH. Debrief with myself or Dr. Kreider at the end of each week to see how things are going, and make sure we're troubleshooting the classes. And encouraging, we have HIPAA laws, so we can't take pictures of patients, but encouraging guidance residents to document their experience via photo and video to encourage more residents to come. And then also maybe develop a med ed related didactic, an area of need that they can add to their didactic curriculum. Report back at least one insight from working in a new cultural context, or flexibility to develop an alternative project of their choosing or interests. And a very similar proposal for our residents when they're doing away rotations in Guyana. That is it. That is the overview of the plan. I want to thank the audience for just like the technical difference in the starting late. Sorry about that, but I also just want to give some thanks to like just the many people who were really supportive of this venture. I just want to thank the Ministry of Health, Dr. Anthony, Dr. Lal, Dr. Morgan, Dr. Freeman, GPHC leadership, Mr. Rambare, Dr. Sameo, Dr. Barry and Dr. Rash Kumar with GPHC and MPH Psychiatry and their faculty and residents, Dr. Lopez with the Masters of Med in Psychiatry, Dr. Ramirez and the anesthesiology team with GPHC, Dr. Hoban and the Columbia team who have invited us to come and present here and been so welcoming, and also Dr. Eric Troy Pena, Shari Jardine, Salia Atif, Alia Hassan, who's in the audience right now, Danny Leon, and Hanna Marler with CGH at Northwell, and then of course psychiatry team, Dr. Young, Dr. Kreider, Alex Martin, who presented earlier, and Dr. Patrice and Sohag Sangani, Dr. Sangani, and Lisa and Gubak to VCT who are here at NPH. So thank you all for your attention, and I'm happy to answer any questions.
Thank you so much for this presentation. It's really interesting to see everything we're doing. It's so comprehensive, and there's so many areas that we cover, which is wonderful. So does anyone in the audience have any questions? Reading and production. That kind of falls within so I mean, a lot of patients go first to testing before they do it. So I was just wondering if they're planning to get family medicine involved in the program.
Yeah, it's a great question, and it's super important. So like a lot of the thing that we're also trying to do is capacity building, right? So in the US, which is super regulated, and like at least in New York, it's like oversaturated with psychiatry. Not everywhere in the US, but in New York, it's oversaturated, right? So Guyana, there's a more need, right? There's only 13 psychiatrists maybe in the country, and even that number I understand is built off of the product of the Masters of Medicine Psychiatry. So a lot of things that we're going to be doing will be primary care based, because it's not, the model is not to train only psychiatrists, only like nurse, like matron nurses. It's like to try to bring a more broad primary care training for the many people who it takes to run a service, while we're also trying to build the expertise and add more psychiatrists. Excellent point. And if you have any kind of thoughts or ideas on how to make things go smoother with integrating with family medicine, I'm definitely so appreciative to hear thoughts about this.
Does anyone else have any questions?
Would you like to say?
So I was just gonna say that I was at the substance use panel earlier today, and one thing that they were talking about was that oftentimes when people come in for substance use related issues, the first thing that they do is like there's no screening really. They kind of just do the most severe treatment first. And I think that the idea of screening is really important for the primary care, assuming because there seems to be like, I think there's sometimes for people coming in, maybe that would help them direct their treatment better, and how they handle things that are coming into the
It's your point is like so important. Like screening, it's like screening is kind of equivalent to like the measurement-based care, like kind of like knowing what's happening to know what you're doing. It's important for on the level of the patient, because if for example, there's a lot of like dual diagnosis or kind of comorbidity things, right? So if like the step of screening is like not carefully looked at, a person might be say treating someone for say schizophrenia when it's really like a substance use psychosis, something that's like a lifelong kind of managed condition to manage versus something that's time limited. So the treatments could be very different on the individual level than when you're looking like on a structural level, like an equity level. So for a department or for a government to really know how to best use its resources, right? You don't want to be putting a lot of like money and human resources when resources are limited into the place with not the greatest need, right? So I think so on both levels, that screening and like data collection is like super important.
Yeah, and the building of electronic medical records definitely too, because from my understanding, a lot of that would probably be currently.
Yeah. Yeah, and finding a way to navigate that so that because a lot of times EHRs in the U.S. context make things like more challenging. So there's pluses or minuses, but like they're really helpful for just keeping track of things. So finding a way that makes sense, that is like helpful and not hurtful. It takes a lot of time. But yeah, super important. Thank you for that.
Yeah.
There's a lot of data on fellowship. Stats in the period as reported by WHO and UNICEF and identified 27% of anxiety in the school age in the Caribbean and Latin America. So, are there any program to address the adults to screen them? Because the early you detect, the better for them to work on. So, are there any program to have school children that can
Yeah, it's a super important comment. So at Northwell we do have a lot of like early intervention programs. And I think when we're trying to support Guyana, we are thinking throughout the lifespan, through children, adolescents, adults, women's health, which is a little bit different from men's health, and this based on global patriarchy sometimes gets like ignored or whatever, and geriatrics. So at Northwell, we have expertise in kind of child psychiatry and also in adolescent psychiatry. I work in a first episode psychosis treatment, like the only patients I see are first episode psychosis. So they're all like teens, young adults who are getting psychotic for the first time, and in that context, the treatment, the response to treatment, and the side effects are all completely different than when you're treating someone with chronic schizophrenia. So just like the treatment is different, but then also things they're like when people are having these difficulties in childhood, you cut it off early and you're not having these manifestations of problems down the line. Like people like kids, if ADHD is identified early, like you're not going to have things like conduct problems when they're adults. So it really is important to like set a person's life trajectory on the right path. And so it's your comment is super important. It's something that we're definitely hasn't gone unnoticed in terms of our strategy. We do intend to take care of kids.
It's not only on focusing on the psychiatric illness, I'm talking about lot of them have anxiety.
Neurotic type things too. Yeah.
Because I've done a survey of 1,500 students. I'm looking at more reading. So I found that 30% of them have anxiety. Of course, I use DMD 8, DMD 7, and then PH2 8. Those are scale, and then we can review. 40% of them have poor well-being. 30% is depression and 30% is anger. It's excellent what to do with that. 1,500, they're all go to 700 on this. And I think that is a very important thing to work on.
It's important. It's like it's also kind of like what to do. It's probably multifactorial, right? It's like identifying early, giving many options for treatments, maybe even treatment in schools, like psychologists in schools. I don't know. I'm unfamiliar with the Guyanese context for the education system. I'm Bahamian, and I know just like although I was raised in the U.S., stories I've heard, of my parents and aunts and uncles who went to Bahamas, even like the structure of the school system, which based on a British structure, was also a little bit like harsh on, like maybe even the structure of the school, at least in the Bahamas, was contributing to the anxiety. So I think when we're thinking about that, we're thinking about like multiple solutions to complex problems. So looking at it in various different ways, and not really, since there are huge problems with like suicidality and psychosis, not overlooking some of the less severe mental illness like anxiety.